Hello everybody, my name is Heather Brown. I'm a registered nurse and instructor with Gurnick Academy of Medical Arts. So this presentation will be for our nutrition course. It is on Chapter 18, Gastrointestinal and Accessory Organ Problems. So this starts 3 big chapters tonight for nutrition discussion and learning. These chapters, in my opinion, are like last week, much more interesting because we're starting to apply all of our knowledge that we learned in the first several weeks here to real disease processes. So hopefully those kind of weeks that are tough in nutrition, it's getting a little bit more interesting for you guys at home. This will be our last big lecture night, lecture day, depending on when you're listening. And then next week will be a lot lighter. So heavy night tonight, but hopefully enjoyable for you guys. So let's go ahead and get started here with Chapter 18, everybody. Here's our introduction slide for Lesson 18.1, Diseases of the GI Tract and Accessory Organs. Diseases of the GI tract and its accessory organs interrupt the body's normal cycle of digestion, absorption, and metabolism. The upper gastrointestinal tract. So we start with the mouth. So patients may have dental problems like tooth decay, ill-fitting dentures. Dentures are huge. We want to make sure our patients have their dentures. A lot of times they can face dentures that don't fit well, and this affects their eating. Mechanical soft diet can be helpful for these dental problems. So that's oftentimes the diet that the doctor will order. Surgical procedures, healing nutrients are administered with high protein, high caloric milkshakes. So if our patient goes through surgery, they could be prescribed high protein or high caloric milkshakes. So here we're looking at tissue inflammation in the mouth. So picture A, top left corner, we have gingivitis, inflammation of the gums. Picture B, we have stomatitis, which is inflammation inside the mouth. Picture C, bottom left, we have glossitis. This is inflammation of the tongue. And lastly, picture D in the bottom right, this is cheilosis, which is cracks in the corners of the mouth, and it can be on one side or both. So these are all different types of tissue inflammation. We're just seeing here some pictures covering a few of those. Here we have the salivary glands. So all I want you to do, please do not spend the time memorizing these for this course. I just want to illustrate that there are several salivary glands, probably more than you expected here. So just showing you that in this picture. Swallowing disorders. So medical term for the throat is the pharynx. The Heimlich maneuver is utilized for choking. Dysphagia is a fairly common problem. So this is extremely common for patients with Alzheimer's, Parkinson's, or a patient who's suffered from a stroke. So dysphagia, what is dysphagia? So think about it for a second. What is it? So dysphagia is problem swallowing. Some common symptoms include unexplained drop in food intake or repeated episodes of pneumonia. So repeated episodes of pneumonia, this is where patients swallow and the food goes down the wrong tube, and we end up where they can have aspiration pneumonia because they've aspirated their food. It's went down the wrong pipe, and they end up with pneumonia. So these patients that have a hard time swallowing, they sometimes stop eating, and then a lot of times we see that reoccurring episodes of pneumonia. And this can be diagnosed by a speech language pathologist. So yes, you read that right, speech language pathologist. So for our patients passed after a stroke, a lot of times the doctor will order a speech therapist or a speech language pathologist to assess the patient, assess their swallowing ability to see which diet we're going to place them on. So these problems are diagnosed by a speech language pathologist. So for residents with Parkinson's, Alzheimer's, that have reoccurring pneumonia and coughing while they're eating, this is probably a sign of dysphagia for this patient. So keep in mind those common diagnoses that we're going to see this with. Warning signs for swallowing disorders. So patients reluctant to eat certain foods, consistencies, or any food at all. So we saw that on the last slide. Very slow chewing or eating, so they're kind of fearful to swallow. Frequent throat clearing, the sound, so trying to clear their throat. Complaints of food sticking in the throat, holding pockets of food in their cheeks, complaining of painful swallowing, regurgitating, coughing, or even choking. And these warning signs, they're going to be deferred to experts, and the diet is going to be adapted based on that patient's individual needs. Problems of the esophagus. So central tube problems. The esophagus, it's the food tube, not the airway tube. So problems here with that central tube include muscle spasms or uncoordinated contractions. So the contractions are very uncoordinated or not rhythmic. Stricture, so anytime we see stricture, that's narrowing of something. So you can have a stricture in the esophagus or narrowing of the tube. Esophagitis. Treatment can include widening of the tube, so this would be in extreme cases. And diet-wise, patients are going to be on liquid to soft depending on their needs and if they're able to advance their diet, meaning perhaps they start on liquid and then we see how they do and perhaps they can go to soft. Now we're moving on to the lower esophageal sphincter, so the LES. We do have a picture of that in an upcoming slide. I'll make sure to point out the lower esophageal sphincter, or LES. The first issue here is achalasia. This is also called cardiospasm, but it does not affect the heart. So it's misleading. You're thinking cardiospasm is a heart problem. But if you think about where the lower esophageal sphincter is, it's very close to the heart. So when there's a problem in a tensing of the esophageal muscle, then it can feel like cardiospasm. So it's called cardiospasm, but it's not truly a heart condition. So this is a lower esophageal sphincter problem. So there's changes in smooth muscle. Nerve muscle hormone controls peristalsis. Remember, we've talked about how peristalsis is that rhythmic movement. Treatment includes dilating the lower esophageal sphincter or cutting the muscle, and patients would need post-op nutrition therapy. Gastroesophageal reflux disease, GERD. So GERD is quite common. A lot of people don't seek treatment. It's a very common thing. The classic symptom is frequent and severe heartburn. So it's caused by constant regurgitation of acidic gastric contents into the lower esophagus. Pregnancy, obesity, pernicious vomiting, or nasogastric tubes are factors. Constant irritation and inflammation. And stenosis, most common complication, but also Barrett's esophagus and esophageal ulcer. So many people with GERD are obese. So we do see obesity and GERD, they definitely go hand to hand. Let's now look at it in a picture. All right, guys, a couple of things here for GERD. So we see this acidic fluid in the stomach. We see it wanting to travel upwards, up into the esophagus. This would be GERD. And then in this picture, we also see the lower esophageal sphincter. So this is the esophagus, and this is the sphincter that controls movement into the stomach. So this is the LES, lower esophageal sphincter, pictured here, as well as this acidic fluid in the stomach trying to push its way back into the esophagus. So we're seeing two different things that we just talked about here in this slide. Hiatal hernia. So this is where a portion of the upper stomach protrudes through the opening in the diaphragm membrane. So we will look at this. At first you're reading it, you're like, what happens? So I'll point it out in the next slide and we'll discuss. It's another thing that's especially common in obese adults. So most of this can be improved with symptoms with weight loss. So roughly 85 to 90% of patients can improve the symptoms of a hiatal hernia with weight loss. So let's look at this, okay, guys? All right, three pictures here regarding hiatal hernia. The picture on the left, picture A, is showing you normal stomach placement. Okay, so the stomach is located below the esophageal hiatus. So that's the esophageal hiatus. You see it pictured, and the stomach's below it. That's normal, picture A. Picture B, we have a paraesophageal hernia. So the esophagus is in its normal position. So the esophagus is not being altered, but we have some of the stomach protruding above the diaphragm. So picture B is a paraesophageal hernia. Picture C is a esophageal hiatal hernia. So this one is elevating the esophagus. So if you're seeing the esophagus, it's being pushed upwards. So we see stomach protruding through the diaphragm, and now it's affecting the position of the esophagus. So once again, these are just to help you understand what a hiatal hernia is for you visual learners, not something I'm going to make you guys label, but just for understanding purposes. Peptic ulcer disease. So a lesion or eroded mucosa usually occurs in the duodenal bulb. The causes of this include the H. pylori infection. So H. pylori is a spiraling rod-shaped bacteria. So if patients have this infection, they are a carrier of the bacteria, and it commonly leads to peptic ulcer disease. Now, not all carriers of H. pylori are going to develop peptic ulcer disease, but it definitely goes hand in hand. Also, a common cause is NSAIDs, so long-term use of non-steroidal anti-inflammatory drugs. This irritates the gastric mucosa and can cause peptic ulcer disease. Now we're going to look at peptic ulcer disease. So the picture on the left, picture A, this is showing you a gastric ulcer. So that's a gastric ulcer. Picture on the right, picture B, all those tiny black particles, that's H. pylori. So that's the H. pylori infecting the stomach mucosa. So here we have gastric ulcer and H. pylori infecting the stomach. More on peptic ulcer disease here. So clinical symptoms. So increased gastric muscle tone, painful contractions when the stomach is empty, and the way that we diagnose this is through a gastroscopy. Or we could do imaging, but the gastroscopy is what we see mostly. So the way patients can manage some of these symptoms is through rest, relaxation, and sleep. These all help ease these symptoms. Medical management, so drugs like antibiotics, antacids, HCl controllers, or mucosa protectors can all be utilized. Lifestyle factors, like I mentioned, rest, sleep, coping skills, and avoid aggravating factors. So factors that contribute to ulcer development include things like smoking, alcohol use, and those drugs like we talked about, the NSAIDs that can be irritating. Dietary management, patients should follow a well-balanced diet, avoiding acid stimulation. So think of those acidic type of foods. One surprising one that is common is black pepper. So black pepper can really cause pain for patients that have peptic ulcer disease. Not one of the common ones you think about, but definitely an example. Other foods include like hot chili peppers, chili powder, alcohol, coffee, and chocolate. So these are different things that the patient can avoid. So now we're going to move into the lower GI tract, the small intestine. So we're kind of making our way through our GI tract here, covering diseases along the way. So in the lower GI tract, the small intestine, there can be problems of malabsorption. So this can occur in any of the three digestive processes: digestion of macronutrients, defect in absorption of essential nutrients, leading to chronic nutrient deficiency. And the most common problems here, if we were dealing with malabsorption and problems here in the small intestine, include chronic diarrhea and steatorrhea. So steatorrhea is fatty diarrhea. This is where there's an excessive amount of fat in the feces, which is often caused by malabsorption diseases. Also, cystic fibrosis and inflammatory bowel disease can cause malabsorption. Cystic fibrosis. So this is a multi-system disorder. We are going to talk about some of these symptoms. So it is the most fatal genetic disease in North America for white people. It inhibits the movement of chloride and sodium ions in the body tissue fluids where they are trapped, causing thick mucus plugs to form. So it can affect the lungs, pancreas, also malabsorption. Remember, we just segued to this from the malabsorption slide that we just saw, as well as the liver and gallbladder, and inflammatory complications can arise. So for the lungs, it can damage airways, causing difficulty breathing. Think of a thick mucus plug there. It would lead to difficulty breathing. For the pancreas, another problem of a thick plug in the pancreas, there would be an obstruction that could block digestive enzyme secretion. Malabsorption, food is left undigested in the GI tract. For the liver and gallbladder, it can clog ducts that lead to degeneration, and it can cause inflammatory complications like arthritis and vasculitis. Nutrition management of cystic fibrosis. So nutrition therapy is critical for these patients. Patients who are able to maintain an age-appropriate body mass index percentile have better overall health outcomes. So very critical. Pancreatic enzymes and nutritional supplements. This is also a critical element. So enzymes and supplements are key. So pancreatic enzymes, replacement products, and nutritional supplements to maintain weight. So enzymes and supplements for these cystic fibrosis patients. Inflammatory bowel disease, or IBD. So this is a general term to describe chronic inflammation of the GI tract. So it's kind of an umbrella term. Persistent activation of mucosal immune system against normal gut flora. So this is where that mucosal immune system is activated, kind of going against that normal flora. It disrupts protective epithelial barrier, destroying the function of segments of the GI tract. And two common forms are both idiopathic meaning like unknown cause. So two common forms that we're going to discuss are Crohn's disease and ulcerative colitis. So we're going to segue into those common forms now. So right before we go into those, nutritional treatment of IBD. So remember, it's kind of an umbrella term for several different things. It's a general term. Lots of information here. I'm just going to highlight the information on the bottom, probiotics and prebiotics. So a probiotic is a food that contains live microbials, which are thought to be beneficial to the consumer by improving intestinal microbial balance. So this is like yogurt, okay? This is a probiotic. A prebiotic are non-digestible foods that promote the growth of beneficial microorganisms within the gut. So we'd want to consider the use of probiotics and prebiotics for these patients with IBD. So they may benefit these patients. So probiotics and prebiotics, they can help relieve the symptoms for our IBD patient. So just highlighting that bottom part of the slide because there's just a lot of information here and we're only going to be going over that bottom part. Crohn's disease. The most common locations are the ileum and the colon. Risk factors include family history and smoking. Symptoms vary, but are usually include abdominal pain, fever, fatigue, anorexia, weight loss, painful and urgent defecation, and diarrhea. Causes chronic deficiencies of vitamin A and D, iron, zinc, and protein energy malnutrition, and iron deficiency anemia. Ulcerative colitis. So this begins at the anus. Involvement is limited to the colon, but similar manifestations to what we saw in the previous slide of Crohn's disease. So we have a lot of similarities here, but this one is specifically limited to the colon. The most common symptoms include urgent diarrhea with blood and mucus, abdominal pain, weight loss, fever, and rectal pain. Resulting malnutrition hinders healing, but not as many deficiencies as Crohn's, except it still has iron deficiency anemia. So here we're seeing the difference between Crohn's disease and ulcerative colitis. Crohn's disease is on the left. We're seeing lesions that skip. So we see different areas of lesions here, the darker color. Ulcerative colitis, remember, it begins at the anus and it is just there in the colon. So this picture can help you distinguish the two, Crohn's disease versus ulcerative colitis. Once again, you don't need this picture for labeling purposes, but just illustrating the learning of Crohn's disease and ulcerative colitis here. Now we're moving into IBS, Irritable Bowel Syndrome. We commonly know it as IBS. IBS and IBD are not the same thing. So we previously covered IBD, now we're moving into IBS. IBS usually causes no ulcer or lesion in the bowel and only involves the colon. So we have a difference here. IBD is the more general term of bowel diseases that cause inflammation in the digestive tract. So now we're on specifically IBS. So this is the most commonly diagnosed GI disorder. Functional bowel disorder in which abdominal pain or discomfort is associated with defecation or a change in bowel habit. Common recurrent pain in the lower abdomen. Small volume bowel dysfunction. It can be constipation and or diarrhea. Excess gas formation. And it's a multi-component disorder. So it affects many things. So I'll go ahead and let you read that last part for yourself. More on IBS here. So an individual approach to nutrition care is essential. Remember, we always want to treat our patients as individuals. A regular diet optimized in energy and nutrients. Eliminate food allergens and intolerances. So you guys all turned in your nutrition project today or previously. This is where we could have them food journal things that seem to be, a problem for them. So it could be used to help them identify troublesome foods. Patients should omit gas formers. Consider prebiotics and probiotics, which we discussed on a previous slide. So we can utilize those same principles here for IBS. And consider use of food diaries. So this would all be helpful for these patients. Diarrhea. So diarrhea is not a disease itself, but a symptom of another underlying condition. So we talked about several different diseases, and diarrhea was a very common symptom. So intolerance to specific foods like lactose. So key here is lactose. Lactose intolerance is a major cause of diarrhea. Acute food poisoning, viral infections. Chronic diarrhea, so lasting more than 2 weeks, can be life-threatening. Globally, diarrhea is the 4th leading cause of death. So crazy, right, when you think about it? So chronic diarrhea, if somebody was to have very watery stools for more than 2 weeks and not have access to healthcare, to diagnostic tests, to doctors, they would become very dehydrated and very weak. So globally, diarrhea is the 4th leading cause of death. IV or oral electrolytes and rehydration treatment may be needed for patients, especially these patients with chronic diarrhea. Now we're moving into the large intestine diseases specifically. So diverticular disease. Diverticulosis is the formation of many small pouches or diverticula along muscular mucosal lining. So I'm going to show you this in a picture. So utilize this information in the next picture, and of course I'll point it out to you. It's caused by progressive increase in pressure within the bowel resulting from low fiber diet. So we'd want to increase fiber intake, therefore increasing the bulk of the feces. Diverticulitis is caused by pockets becoming infected. Underlying age-related pathogenesis may develop in response to chronic low-grade inflammation. So age is a factor. So approximately 3/4 of all people older than 80 have diverticulosis. So let's look at this in a picture. For some of you, the words, you're like, what is she talking about? So let's look at it in a picture and we'll discuss more. All right, guys, so diverticular disease. So the top is what we want. The bottom is what we don't want. So the top picture is good. So the top picture, we see pressure trying to collapse the bowel here. So it's pulling the stool longitudinally and the stool is moving along. In the bottom picture, this is one of diverticular disease. So what's happening here is the pressure is pushing in. We have stool with not much bulk to it, and the inwards pressure is going to create that diverticula. What's going to happen is the stool is segmented. We've got that pressure pushing in. If those diverticula were to become infected, that's when we would have diverticulitis. So we've got the inward pressure and it's creating a pocket. So let me show you which pocket. So this pocket here. So what's happened is that pressure has actually created a pocket. The way that we can combat this is by adding more bulk to these feces, so a higher fiber diet to get more like the top picture. The top picture is good. That's what we want. We want a nice bulky feces. The pressure's not creating any pockets. The bottom, when those pockets become infected, we have diverticulitis. And the bottom, we're looking at diverticular disease, diverticulosis, that forming of those small pouches. So patients must increase their fiber intake. So treatment of diverticulosis includes a diet that is high in fiber. We can see how fiber would definitely help that stool on the bottom. Bulkier stool, we would prevent that pocket. Constipation. Normal, so in quotes, normal elimination varies greatly. So what's normal for each person is very different. Common short-term problem causes include nervous tension and worry, neurologic or neuromuscular problems, changes in routines, side effects of medication, frequent laxative use, low fiber diet, which we just hit on, and lack of exercise. Dietary management with natural laxatives is important. So to reduce the incidence of constipation, we want to encourage our patients to take in natural laxatives. So we don't want to say, great, take another med, great, take another med. We want to encourage natural laxatives. Now, if a patient does end up needing other laxatives, that's fine, but we want to encourage natural things such as dried apricots or prunes are also good. So we want to add fiber and bulk to prevent constipation. Natural laxatives like dried apricots and prunes would be great examples. Here we're moving into our next lesson, lesson 18.2 on food allergies and intolerances. Food allergies result from an inappropriate immune response to certain proteins found in food. Underlying genetic diseases may cause metabolic defects that block the body's ability to handle specific foods. Food allergies and intolerances. So here we're going to go over the two. Food allergy. This is where the body reacts to protein as if it were threatening foreign object and launches a powerful attack. The worst of all is anaphylactic shock. This is the most severe reaction. This is where we see the throat closing up. This is the scary, most severe reaction. Food intolerance is not life-threatening and are non-immunologic in origin. So this includes adverse reactions to food or food constituents. Lactose intolerance is the most common, and avoid offending food product is treatment. So if it causes an intolerance, we want to avoid it. So we're seeing the difference between food allergy and intolerance. Here's a list of common food allergies. Most commonly, protein found in eggs, cow's milk, peanuts, tree nuts, wheat, crustacean shellfish, and soy. So signs and symptoms would be hives, nausea, diarrhea, abdominal pain, and perhaps respiratory symptoms such as wheezing. Your patient might not have all of these signs or symptoms, so just a couple. More information on common food allergies here. Recommendation would be a food elimination diet. If it causes the problem, eliminate it. There's also skin prick tests that can be performed to see what the problem is. And an oral food challenge. So children tend to outgrow allergies to milk, eggs, soy, and wheat, but oftentimes they don't outgrow other allergies, but those are the ones that they tend to outgrow. Dietitian can provide guidance on food substitutions or special food products. and recipes modified to maintain nutrition needs for growth. Celiac disease. So this is an autoimmune response to the proteins in certain grains. So this is our body attacking ourselves. It's an autoimmune response. So it responds to things like gluten in wheat, corn in barley, secalin in rye, and for simplicity, it's referred to just as gluten. Oats can be cross-contaminated with these proteins, but oats not problematic for celiac disease. So if they're cross-contaminated, then it would be a problem, but oats specifically aren't a problem. Symptoms for the patient, the two big ones are diarrhea and steatorrhea. So remember that steatorrhea, that's the fatty stools. So those are the big ones, diarrhea and steatorrhea. It can also lead to unintended weight loss. Progressive malnutrition are secondary effects to gluten reaction. So picture here of celiac disease. Picture on the left, picture A, that's a good thing, okay? Happy face on the left, that's what we want to look like. This is a normal mucosal biopsy. The picture on the right, picture B, this is what we don't want. So what's happening here is the celiac disease activating a protein. What's happening is the mucosal surface of the small intestine is damaged. So we have surface damage all in here, okay? Surface damage in here. So this leaves the villi that are malformed and few remaining functional microvilli. So this is what happens with celiac disease. So normal on the left and celiac disease biopsy on the right. What we're viewing on the right is that mucosal surface of the small intestine is damaged. All right, guys, wrapping up celiac disease here. Patients would want to avoid all dietary sources of gluten. Wheat, rye, barley eliminated from the diet. Corn, potato, rice, and others can be used as substitutes. Careful label reading because many products use gluten-containing grains as thickeners or filler. So the picture on the bottom, that's the gluten-free, so that's for our celiac disease patients. And monitor for vitamin and mineral deficiencies. One thing I'm going to cover here in off to the side is malted butter. So for me, whenever I started teaching nutrition, I didn't know what malted. So malted milk, so this contains gluten, so barley and wheat flour. So our patients want to avoid malted things as well. So malted milk contains gluten, barley, and wheat flour. So they want to avoid anything malted as well. So just as a side note for you guys, of additional things that our patients want to avoid is malted products. All right, so we did most of the big GI things, but remember we're GI and accessory organs. So now we're going to go into those accessory organs. We're starting with liver, so liver disease. Liver has excellent regeneration ability, so it can regenerate itself. Fatty liver disease is from alcohol abuse, alcoholic liver disease, ALD, otherwise called non-alcoholic fatty liver disease. Fat accumulation in the liver is steatosis. Sorry, that's about the best I'm going to do there. Excess fatty acids in circulation are stored in the liver. Treat with a balanced diet and really want to stress avoiding alcohol. Possible antioxidant supplementation and enteral nutrition therapy. So this is definitely for the patient with pretty severe liver disease is possible antioxidant supplementation and enteral nutrition therapy. Hepatitis, so sticking on the liver, this is inflammatory condition of the liver caused by virus, bacteria, alcohol, drugs, or toxins. So it's usually the result of a viral infection, alcohol abuse, or drug abuse. That's what we see the most. Most common are viral infections, Hep A, Hep B, and alcohol abuse. Treatment is based on bed rest and nutrition therapy. So they want to avoid those substances that affect their liver. Diet of adequate energy and our macro and micronutrients. 4 to 6 small meals a day, so not big meals, small meals. Limiting sodium to 2,000 milligrams a day. And they want to make sure to control the ammonia level. All right, so another liver disease here, cirrhosis. A chronic liver disease in which the liver is damaged beyond repair with scar tissue and fatty infiltration. So the liver usually removes ammonia from the blood. So with cirrhosis, that capability is lost. So if we're not removing ammonia, it's going to build up. If it continues to build up in the blood, it ends up damaging the brain. So, and we do have a slide on that. So, very big issue here, cirrhosis and the buildup of ammonia. So, associated with alcoholism, hepatitis, and inherited diseases. It results in portal hypertension, hepatic encephalopathy, which we'll cover in the next, esophageal varices. They can rupture and lead to hemorrhage and death, and ascites. So ascites, this is accumulation of fluid in the abdominal cavity. So a major nutritional problem related to the development of ascites is lack of protein or protein deficiency. So low plasma protein levels contribute to ascites. So we want to make sure that patients are getting adequate protein because low plasma protein contributes to ascites. Medications are limited and nutrition therapy is used. So like I said, there would be an emphasis on protein for those patients with ascites. So we're segueing into hepatic encephalopathy. So as cirrhosis continues, so the previous slide, blood can no longer circulate normally through the liver. Ammonia and nitrogen cannot be eliminated. So that's the big function of the liver. So these things will build up, which produces ammonia intoxication, so too much ammonia. And the patient can actually go into a coma. Treatment focuses on removing the sources of excess ammonia. So they remove the excess ammonia, and these patients are typically very, very confused. So the primary objective is going to remove excess ammonia for this patient. So I once had a hepatic encephalopathy patient, a very hardcore alcoholic with ammonia levels through the roof. Liver was not functioning. Liver could not process ammonia. It built up, and eventually she didn't know her name. She was only in her 40s. She looked much, much older. She didn't know where she was. She didn't know who she was. She didn't know who anybody was. And the way that we remove excess ammonia is through diarrhea. So we give medications that cause the patient to have diarrhea. We hydrate them, and eventually days of repairing that liver function, hydration, and getting rid of the excess ammonia, the patient, I assisted her to the bathroom over my 3 12-hour shifts, probably 25 times. Small amounts of diarrhea, completely confused every single time. Eventually, I came back to work after a day off, and she looked at me and she said, "Who are you?" And I was like, she had no idea who I was. The ammonia level had eventually come down. Her brain had been able to get proper blood supply at that point, and she didn't remember me taking care of her for 36 hours. So super scary. But once that ammonia level dropped and we could reduce it, she was able to remember certain things. And actually, after several days of caring for her, I was finally able to kind of have a conversation with her. So hepatic encephalopathy, here we have the liver eventually damaging the brain with the goal of removing ammonia to restore blood function to the brain, and the focus there on removing that excess ammonia. Management of cirrhosis. So we'd want to avoid hepatotoxic substances. I did better the second time. 4 to 6 small meals daily. Energy and carbs, protein. So we talked about protein and ascites. Fat is limited to 30% of kcals if steatorrhea is present. So if there's fat in the stool, then we want to make sure that we're keeping an eye on that fat. Enteral or parenteral nutrition support, vitamin mineral supplementation, and once again, small frequent meals. Gallbladder disease. The gallbladder functions, so it concentrates and stores bile. Remember that bile is an emulsifier, it breaks down fat. So gallbladder functions to concentrate and store bile. Then it releases the concentrated bile into the small intestine when fat is present from the diet. So when fat is there, bile is released because that bile is going to break down the fat. Cholecystitis is gallbladder inflammation. So it usually results from low-grade chronic infection. So cholecystitis is gallbladder inflammation. Cholelithiasis is gallstone formation. So cholelithiasis is gallstones, and cholecystitis is inflammation of the gallbladder. With cholelithiasis, cholesterol separates out and causes gallstones. Diet therapy centers on controlling fat intake. So that's going to be the biggest thing, is controlling fat intake. For patients with gallbladder problems, if the gallbladder main thing is bile storage and releasing, and we know that bile is an emulsifier and breaks down fat, we'd want to watch the amount of fat that these patients take in, because they're having a misfunction of that gallbladder and bile. So controlling fat is key. Therapies could be removal of the gallbladder, which is a cholecystectomy, litholysis, and nutrition therapy. Pancreatic disease, pancreatitis. So this is our last accessory organ that we're going to be looking at, is the pancreas. Inflammation of the pancreas inhibits its release of digestive enzymes. This can be acute or chronic, so long-term or short-term. Causes, the number one cause is excessive alcohol consumption. So that's the main cause. The pancreatic duct can also become blocked by gallstones. Hereditary cystic fibrosis or autoimmune disorders can also be a cause. Remember, cystic fibrosis, we talked about forming of mucus plugs, and that can be a problem here with the pancreas. So if it's acute, the treatment is NPO with hydration. So NPO is nothing by mouth. So the hydration is done via IV. So for these pancreatitis patients, big is you don't feed them. They don't eat, they don't drink, but you do hydrate them with IVs. Eventually, they'll be able to have ice chips and move on with their diet. But initially, definitely, it's nothing by mouth with hydration. For our chronic pancreatitis patients, we want to make sure they have adequate energy and nutrients, especially protein, lower in fat, and avoid alcohol and smoking. So everybody, this wraps up chapter 18 on GI and accessory organ problems. Remember that this is kind of our last big day or night of lecture. Hopefully you guys found this all useful, and enjoy the rest of your lecturing for class today.